Hi and welcome back to another video of Medic Notes. This video is on diabetic retinopathy. Diabetic retinopathy is an umbrella term used to describe a number of characteristic ophthalmological pathologies in the presence of diabetes. Some of the terms and causes overlap with hypertensive retinopathy and have common final pathways. Generally, diabetic retinopathy can be broken down into the categories shown in this table. Non-proliferative retinopathy includes findings like cotton wool spots, dot and blot hemorrhages, hard exudates, or microaneurysms. Proliferative retinopathy includes neovascularization, which means formation of new vessels, arising from optic disc or vessels, and macular edema. The associated conditions are diabetes and hypertensive retinopathy. This is a fundoscopic picture of the left eye, seen in a diabetic patient. Over here, you can see some small dot hemorrhages, microaneurysms, and lipid exudates. Chronic hyperglycemia is thought to be the main reason for diabetic retinopathy. It ultimately leads to two key pathological states: altered vascular permeability, and ischemia of the retina with associated neovascularization. There are many proposed mechanisms for diabetic retinopathy changes. Endothelial dysfunction. The retinal endothelium is more than a barrier for blood vessels. It mediates vascular tone and releases factors involved in hemostasis, vessel growth, and inflammation. Endothelial dysfunction may be precipitated by hyperglycemia, insulin resistance, and hyperinsulinemia. BMP. Bone metalloproteinases have been shown to be upregulated in patients with diabetic retinopathy. They have been implicated in the promotion of VEGF and inflammation. Chronic hyperglycemia, like I mentioned just now. Hyperglycemia impairs retinal blood flow autoregulation, causing increased flow, leading to shear stress on retinal blood vessels. This leads to the release of vasoactive substances, which results in vascular leakage and macular edema. It also contributes to sorbitol production. Sorbitol is formed in the breakdown of glucose. Excess sorbitol can cause osmotic damage to cells and alter other proteins, leading to altered vascular permeability. Advanced glycated end products. Excess glucose combines with amino acids and proteins, inactivates key enzymes, alters cellular proteins, induces reactive oxygen species, and contributes to inflammation. This results in vascular damage and ischemia. Vascular endothelial growth factor. VEGF is induced by retinal hypoxia and can cause breakdown of the blood-retina barrier, leading to macular edema. VEGF is also associated with the new blood vessels seen in proliferative retinopathy. Inflammation. Increased adhesion of leukocytes to capillary walls decreases blood flow and increases hypoxia. This can contribute to breakdown of the blood-retina barrier and development of macular edema. A chronic inflammatory state has also been shown to release cytokines that induce insulin resistance, worsening glycemic control and endothelial dysfunction. And lastly, microthrombosis leads to occlusion of retinal capillaries, ischemia, and capillary leakage. Leakage stimulates growth factors including VEGF. Let's look at its sign value. Diabetic retinopathy changes are very significant in diabetes diagnosis. They are seen in almost all patients who have had type 1 diabetes mellitus for 20 years. 80% of patients who have had type 2 diabetes mellitus for 20 years. 50% of patients with type 1 diabetes for 10 years, and 10% of patients with type 2 diabetes for 10 years. So we can see that people with type 1 diabetes are more prone to have diabetic retinopathy. That's all for this video. Thank you.